Word on this computer. Oh, Dr. McBride is back. Ooh, ooh. Dr. McBride, I could share the PowerPoint if you want to start, and you could just tell me next slide if that works for you.
I have the PowerPoint too.
Oh, okay. That works then. Whatever you want to do.
Get out of the back. So do you sort of, let's wait like maybe 2 more minutes.
Okay.
Yourselves on my screen.
Yeah, we could see the PowerPoint.
Okay. But you don't see yourself.
No.
Welcome everybody. So, hello. My name is Dr. Daryl McBride. I'm one of the co-chairs of BOLD. I'm here with the fabulous, the wonderful, the exonerated Dr. Vicky Sapp. Also co-chair with me and BOLD. And we have Philip here as well, who's going to be helping us to our closing ceremony for our Men's Health Matters Month. So again, this is the Geisinger's Bowl, the Black Outreach for Leadership and Development, and one of the ERGs here at Geisinger Medical Center. And we partnership with the BSPCC and here to put a particular series. I would again like to thank Priscilla, who's here with us today, Faith, and also Dr. Vicky Sapp yet again, the Exonerate. Here, my name is Dr. McBride. Again, I'm with BOLD and the co-chair. Special thanks to Arthur Breeze, Brian Lieberman, Michelle Anto, who's given us a lot of our administrative support, the marketing team, Heather is Zach Booth, and Anna. All right, so as you can see, we had a lot of lectures this month. Our last one, again, is today, June 29th, with Cancer in Black Men in Science. Right, and again, we'll just briefly go over.
Dr. McBride, you sound very faint. Can you do anything with your sound?
Hello, is this better?
Oh, that is wonderful. Thank you.
Have a mic here. I'm in other territory, so I can get closer to the mic. Not a problem. So again, this is the Black Outreach Leadership and Development ERG. We embrace a culture of inclusion, build awareness and appreciation for diversity, and we really span the entire Black diaspora, Black African American, Afro Caribbean, Afro Latinx, et cetera, et cetera. And we would love to welcome you guys to our organization, and you can join through these processes. So you can reach out to Mr. Brian Lieberman, either me or Vicky Sapp or Mr. Arthur Breeze. There are also other ERGs, Women's Lead, G Pride, VetNet, and GAIN. And please get to those through these emails here. We also have a giveaway. So the first 5 people to sign up will win a mug, a bold mug. These are awesome. I have 3 of them at home. I recommend you go get one, or at least try. You never know. And I would like to pass it off to Miss Priscilla Cabral to give our spotlight.
Hi, everyone. My name is Priscilla Cabral. I work here at Geisinger Commonwealth School of Medicine. I'm going to be presenting our Black Excellence in Medicine Untold Story series. We've been doing this series throughout the month. It's to spotlight, is to create and highlight some of the important people in the Black community who are talented professionals. This month, we highlighted a few Black men that have been very successful in the medical profession. We did Dr. Tuckson, who is a manager of director of his own health and consulting agency. Dr. Vicker, he's the vice president and dean at his university. Next slide, please. Dr. Mighty, he's the dean of the College of Medicine at Howard University. Next slide. Dr. Carlisle, who is the president and chief executive officer at his institution. Next slide, please. Dr. Thomas, we reviewed on the 11th. He's an associate professor in medicine at Duke University. Next slide. Dr. Moore was the one we reviewed last time. He also is in cardiovascular disease and electrophysiology. And then I think we're at where we are today with a Brian H. Williams. Let me see, hold on. And Dr. Williams is a trauma surgeon, professor, and public speaker, and former aeronautical engineer. He is extremely passionate about racial disparities within healthcare and travels all over the country to advocate for racial injustice and health equity. He is most known for the treatment he provided for the victims of the 2016 Dallas police shooting. He is currently authoring his first book titled Race, Violence, and Medicine, a Memoir. He is currently practicing at the University of Chicago in medicine. And then we have one more to do today. Yes, Dr. Cedric M. Bright. Dr. Bright is currently the Associate Dean of Admissions at East Carolina Brody School of Medicine. He has a vast amount of experience that includes over 31 years in the healthcare industry. He formerly served as a medical ambassador to Ghana and as the 112th president of the National Medical Association. He's a tremendous advocate for Black and Brown patients, proving his dedication by speaking about disparities in healthcare at the Congressional Black Caucus. All these men are great examples for those in the medical profession. And I'm going to turn it back over to Dr. McBride to introduce our speaker.
Hello, hello. I'm back. The sound is good this time, right? Okay, wonderful. So I'm going to introduce the speaker. This is Mr. Cy Wilkins, and this is the title of this is Cancer in Black Men, the Disparities and the Science. Dr. Wilkins is an awesome guy and a personal friend of mine, so I want you all to sit tight and be shocked and astounded by his rhetoric in this. Dr. Wilkins is an assistant attending of hematology, servicing at Memorial Sloan Kettering Cancer Center in New York City as one of the nation's oldest and largest centers for cancer care. He is a certified oncologist and hematologist. His practice focuses on blood disorders that develop in cancer patients during and after treatment. Dr. Wilkins' interests are disparities in cancer care and also introducing the diversity of our current and future oncology workforce. I'm happy and pleased to present Dr. Cy Wilkins and his presentation. I will stop sharing and I will give you the mic, friend.
Okay. Okay. Do you guys see my slides?
Yes.
Yes. Okay, great. See my slides?
Yeah, so you just want to switch it over for
Okay.
display.
Okay. Great. Right? Okay. We're good to go. Okay. Okay. Thank you, Daryl, for that excellent introduction. I'll just get into it then. Again, my name is Cy Wilkins. I'm a hematologist and oncologist at Memorial Sloan Kettering in New York City. So my task over the next 45 minutes is going to be providing you with some of the pretty hard, sobering facts about cancer disparities in Black males. We will explore potential contributors to these cancer disparities. I'll also offer suggestions for addressing this disparity, these disparities for Black men, their families, providers, and allies. And finally, I'll wrap up with some words of wisdom if you or a family member are facing a cancer diagnosis. Okay, so does everyone know who this is?
Chadwick Boseman.
Yeah, this is Chadwick Boseman. So I chose to begin my lecture with Chadwick Boseman, not just because he was an exceptional actor and some of my favorite films, but as an oncologist, he has, due to his recent death, he has become the essentially the face of a recently recognized type of cancer. It's called young onset colorectal cancer. This type of cancer affects individuals below 50 and is hyper aggressive and has extremely poor outcomes. And unfortunately, the rates of this diagnosis is increasing pretty quickly. Within the last 15 years, there has been a 15% increase in the diagnosis of this type of cancer. So a couple definitions before we get into the full lecture. So a health disparity is a particular type of health difference that is linked with economic, social, or environmental disadvantage. This usually affects folks who are have characteristics historically linked to discrimination or exclusion. Second definition is from the National Cancer Institute, and this is the definition for cancer disparities. which are differences in the incidence, prevalence, mortality, and burden of cancer and related adverse health conditions that exist among specific population groups in the United States. So let's talk about cancer. So this graphic, and no offense to the ladies in the audience, but I'd like you to just to focus on the male here and the numbers beside him. So in 2021, there will be an estimated 2 million new cancer cases and 600,000 cancer deaths. We can see here that in males, the most commonly diagnosed cancer is going to be prostate, followed by lung, and then colon rectal or colorectal cancer. Now, this is not the same table as the one above. This one is the actual deaths. So what we can see here is that lung cancer by far is the leading cause of death in males, followed by prostate and colorectal cancer. So because this series and this lecture is about Black people, I'll start off with some statistics about Black people. So currently there is an estimated 44 million Black Americans. They're the second largest racial ethnic group behind Hispanic Americans. And from this chart here, you can see that the majority of Black Americans live in the Southeast. And if Black Americans don't live in the Southeast, then they're usually concentrated in large metropolitan areas. So the Black population is increasingly becoming very diverse due to immigration. The Black immigration population has increased fivefold since 1980. In 2016, 4.1 million Black people in the United States considered themselves immigrants, which is 10% of the US Black population. So this diversity comes from immigration from the Caribbean. About 50% of immigrants are from the Caribbean, with Jamaica and Haiti making up the most immigrants from the Caribbean. And then around 40 or so % of Black immigrants are coming from Africa. And about 7% come from Nigeria. And I wanted to include this picture here because this is a family where, a Nigerian family where they're all doctors. So an interesting thing about immigrants from Africa is that they are the population most likely to have a college degree or higher. 59% of Nigerian immigrants have a bachelor's degree or higher. So it's widely accepted that the incidence in cancers changes to the level of the new host country for immigrant folks in 1 to 2 generations. That this means that immigrants, regardless of origin, will eventually take on the burdens of Black people in the United States. And one of these burdens are that collectively, Black Americans have the highest death rate and the lowest survival of any racial group in the United States when it comes to cancer. So this bar graph shows you, this illustrates the incidence by race, ethnicity, and sex of cancer. And here we can see that the largest bars here, okay, blue is male, red female, are for Black Americans. Now, when it comes to Black males, the reality is even more concerning because Black males have the highest cancer incidence rates. And when they're diagnosed with cancer, they have the shortest survival and highest death rates of any demographic in the United States. And again, this is illustrated here. You can see that this blue bar here is Black males, the death rates of Black males, and you can see that it far exceeds any other demographic. So looking at the trends in cancer over the last 50 years, the cancer incident rates in males has for the most part decreased over the last 50 years. You can see this one blip in, well, prostate cancer is the most commonly diagnosed cancer in males. But you can see this blip here, and this is when screening with PSA came around. But it's since fallen because it's been noted that PSA screening has no really, for most people, most demographics, has no mortality benefit. So there's less screening being done. Lung cancer incidence has declined steadily in the recent decades, which is important. And this is due to decreased rates of smoking. Looking at the cancer incidence rates, again, we can see that in both Black and white males, the cancer incidence rates are higher, but they're much more higher in Black males. Black males currently, compared with white males, have a 9% increase risk of being diagnosed with cancer, and a 22% increased risk of dying from cancer, again, compared to their white counterparts. So what are the causes of cancer disparities in Black males? So this is the last definition for you guys. And it's health determinants, which are a range of personal, social, economic, and environmental factors that influence health status. And the next figure here is an infographic, which goes through some of these health determinants. There's many different complex ways to organize them, but you can see here there are environmental factors, behavioral factors, social factors, clinical factors, cultural, psychological factors, and biological and genetic factors. The disparity in cancer in Black males is due to a complex interplay of all of these. So in the next couple of slides, I'll show you or demonstrate to you how these determinants affect the incidence and death rates in the top 3 cancers. Okay, so let's talk about colorectal cancer. Okay, this is the 3rd most common cancer in the United States. The incidence is 24% higher in Black males compared to their white counterparts. The mortality rate is upwards of 47% higher in Black males compared with their white counterparts. Males tend to be diagnosed at a later stage, present with more advanced disease, and also have increased rates of proximal colon involvement. So in colon cancer treatment, we divide the colon into proximal and then distal. So like a rectal cancer would be distal. The proximal colon cancers tend to be more aggressive and have a poorer prognosis. So we can see the risk factors here for colon cancer, and unfortunately, these risk factors are very prevalent in Black populations. Lack of physical activity, obesity, poor diet, low fiber diet. There's also processed meats and red meats, which are a risk factor for colon cancer. So the next thing I'm going to talk about is healthcare access, the quality of care, because there's a lot of data showing that Black folks receive less recommendations for colorectal cancer screening than their white counterparts. And the rationale for this is apparently perceptions that Black folks or Black males are unable to pay because Black males do have significantly higher, lower rates of having insurance than their white counterparts, but also the availability of the endoscopies who's doing the colonoscopy for screening. There's a perception that the endoscopist is not going to be close or have an office in the area that this Black male lives in, and if he has insurance, it's probably not going to be accepted. So just some biases there. And then there's also data saying that Black patients receive colonoscopies from less skilled endoscopies, which is a big endoscopist, because this is a big issue, because if you are unskilled as an endoscopy, you are more likely to miss precancerous and cancerous lesions. Just finishing up here with colorectal cancer. Once Black men are diagnosed with colorectal cancer, they are less likely to receive standard of care treatment, either surgery or chemotherapy or both. However, there was one interesting clinical trial in patients with stage 3 colorectal cancer. So this is colorectal cancer that you've gone to surgery and now you're receiving chemotherapy after to prevent recurrence. And because of the strict nature of clinical trials, this trial actually found that there was no difference in survival rates in white versus Black males, which is, very surprising, and is a reason why more Black males and more Black people in general should participate in clinical trials. So the conclusion, and this comes from the American Cancer Society, is that insufficient access to care and health coverage accounts for over half the survival disparity between Black and white males. Now moving on to prostate cancer. So 30% of Black men will be diagnosed with prostate cancer. The incidence or the risk of being diagnosed with prostate cancer is 76 higher in Black males compared to white males. And prostate cancer is the second leading cause of cancer-related death. So in 2019, prostate cancer resulted in the deaths of about 5,500 Black men. So when Black males are diagnosed with prostate cancer, it's usually at a younger age. There's an increased likelihood that at diagnosis, Black males will have metastatic disease, okay, meaning disease that has spread to other areas. Their tumors tend to have more aggressive histology, meaning they are more aggressive tumors. And the some of the risks in Black males are age, of course. As you age, you're more likely to get prostate cancer. A big one is the age of affected relatives and the number of relatives with prostate cancer. So if you have a first-degree relative with prostate cancer, your risk of getting prostate cancer increases by 2 to 3-fold. If you have 3 first-degree relatives, it increases by 11-fold. And brothers of men diagnosed with prostate cancer under 65 have a 6-fold increased risk of also developing prostate cancer under the age of 65 themselves. So in Black men, obesity and tobacco are associated with more aggressive tumors. When it comes to treatment, and again, this is going back to healthcare setting and bias from healthcare providers, prostatectomy, which is one of the definitive or curative treatments. Once Black males get prostatectomy, compared with white males, they tend to recur more and recur with more aggressive disease. Black males are less likely to receive radiotherapy, which is also a curative option for treating prostate cancer, and less likely to receive genomic profiling. And genomic profiling is very important because it tells how aggressive the prostate cancer is, likelihood of spread, and potentially the need for treatment. Finally, we'll finish up with lung cancer. Black men have the highest lung cancer incidence and mortality rates of any demographic in the United States. And this is very interesting because historically, Black men have pretty low rates of tobacco use or smoking. Black men with lung cancer, again, tend to be diagnosed at a later stage, which is a significant risk factor for poor outcomes in lung cancer and any cancer, period. They're less likely to receive surgical treatment and also less likely to receive any treatment at all. They're less likely to be offered surgery. And the explanation for this, because this has been an ongoing trend and something that was found to be concerning, is that in Black folks in particular, if they have 2 or more comorbid illnesses, meaning diabetes and high blood pressure, or diabetes or high cholesterol, many times they would be refused surgery. There were studies done showing that having these comorbid illnesses does not make the surgical outcomes worse, but this kind of bias still continues. There's also another issue with surgery being denied to folks who don't have regular care, like a primary care physician or an oncologist. And then because of a lot of different things, but mostly because Black people tend to become passive when it comes to their cancer care, and many times defer to their providers to make decisions for them. Black folks and Black males are more likely to refuse surgery, and surgery for most cancers is the only curative therapy. So let's quickly talk about some socio-structural determinants. So 21% of Black families live below the poverty line. It's said that for every dollar made by a white person, a Black person will make a penny. Historically, the unemployment rates of Black males has been on average twice that of white males. The reasons for this is complex, has a lot to do with educational level, area that people live in. If there's history of incarceration, you can't get a job, transportation. So this is a very complex thing. It's not that people just don't want to work. And another interesting tidbit here is that even if you are working or you are educated, have a college degree as a Black male, your income compared to someone with the same amount of education and qualifications is significantly less. Now, quickly, I just wanted to touch on some of the hereditary cancer syndromes. I won't spend too much time on them because I will mention them in some of the screening when I go through screening. But the other thing about the hereditary cancer syndromes in Black men is that there's little information on these syndromes, and there's a lot of controversy. The reason is that, not a lot of Black men are on clinical trials where their tumors are being sequenced, and therefore we just don't have, any, hard data. So to wrap up the determinants of the cancer disparities, so it's complex interaction of lots of things, transportation, where you live, lifestyle, maybe even some genetics, but upwards of 85% of cancer disparities in Black men are due to socio-cultural or health access related issues. So genetic or hereditary cancers only account for a small proportion of the disparity that we're seeing in cancer. So addressing cancer disparities as a Black male. So these are some of my recommendations. The first one is to know your family history, okay? Because despite I just told you that, we don't know much about hereditary cancer syndromes in Black males, we do know that in Black males, less than 50, when it comes to colorectal cancer, 20% of the cancers in Black males less than 50 are hereditary, and 10% in men older than 50. And then we also discussed prostate cancer and the close link with your first degree relatives if they also have prostate cancer. So you also should be aware of the screening guidelines You don't have to know them in detail because that should be left to your primary care. But these are some of the organizations that put out guidelines, including my hospital. But a lot of these organizations have patient-friendly patient-friendly documents to help understand the guidelines, and also infographics, which are always fun. So this is one infographic about colorectal cancer screening. And this is from the American Society, the American Cancer Society. Basically, you start discussing cancer screening at 45, and normally you get screened from 45 to 75. And after, once you turn 76, then it's a kind of risk benefit discussion with your primary care, but after 85, you don't no longer need it. What's the interesting thing now in colon cancer screening is that we're getting more non-invasive testing, so non-colonoscopy methods for detecting colon cancer. I'm not sure if you guys have heard of Cologuard or FOBT. These are actually being targeted to Black populations to increase the rates of colon cancer screening. And just last thing on colon cancer is that for individuals who have a family member diagnosed with colon cancer less than 60 years of age, colon cancer screening should begin at 40 years old or 10 years before the affected relative was diagnosed. Important thing to remember. Okay, now prostate cancer screening is very controversial because, again, multiple studies have found that there is minimal to no benefit to screening. However, this does not apply to African American men. So you can see here that these are the risk factors for having prostate cancer and likely more aggressive prostate cancer. And African American descent is one of them. Symptoms are really non-specific, so they don't matter. But based on you will tally this and you come up with your risk. And based on your risk, you're given an age at which time you should start discussing PSA screening with your primary care. And finally, lung cancer. For those of you who aren't aware, the recommendation is now for folks, and this is recently changed, for folks who are 50 to 80 years old, who are currently smoking or quit in the last 15 years and it's no longer 30-pack years, it's 20-pack years. They should undergo yearly low-dose CT screening for lung cancer. So the last thing is one of the simplest things you can do to lower your risk of cancer. For the American Cancer Society, 18% of cancers are preventable by pursuing a healthy lifestyle. They recommend achieving and maintaining a healthy weight throughout life, consuming a healthy diet, which includes at least 2.5 cups of vegetables daily, lots of whole grains, avoiding processed meats. And then for males, maximum 2 alcoholic beverages daily. It's 1 for females. And the final thing they recommend is at least 150 minutes of moderate to vigorous activity weekly. Now, the final thing as a Black male that you can do to reduce these disparities in cancer is to become a physician or a medical provider. There is, as you will see, a lack of diversity in oncology. But when we do get Black and brown oncologists, they're more likely to work in underdeserved communities. For patients, having a Black or brown physician, it brings trust and comfort. And studies have shown that the most important factor in Black males who choose to undergo colorectal cancer screening is trust in their primary care. Increase in minority oncologists will lead to increased access and improves quality of care in underdeserved communities. So again, unfortunately, we just don't have a lot of Black oncologists. So in 2016, there was just over 12,000 oncologists in the United States. And just to put things in reference, 13% of the US population is Black. Only 2.3% of oncologists are Black. There's a trend in medicine now that there are more and more females, Black females, becoming physicians and oncologists, and less Black males, which is a concerning trend. And just to kind of give you an example here, at my institution, we're all divided into divisions, division of solid tumor, division of hematologic malignancies. I'm in the division of hematologic malignancies, and out of 90 faculty members, there are currently 4 Black faculty, 2 females, 2 males, and I am the only male Black faculty that actually has regular interactions with patients. Not to offend my my friend, but he's a physician scientist, so he has minimal interaction with patient care. So it's just me on the in the this division of 90 physicians. So addressing cancer disparities as medical providers. So we all know that there is a long history of abuse of Black people and their bodies in the name of medicine in America. The picture on the left and the caption below is actually from South Carolina Medical College. I believe that's now the Medical University of South. I believe it's is it South Carolina Medical? It's MUSM, I think, Medical University of South Carolina, or MUSC. Either way, they actually so during time before emancipation, it was quite often for training medical students, which were exclusively men, to dig up slaves that were buried and dissect them, because dissecting was an integral part of medical education. And this picture is actually showing dissection of a Black male. This medical college also set up a clinic where they advertised they would take care of colored populations, but the clinic was just another excuse to poke and prod folks who couldn't give consent. Yeah, it's pretty sad history there. A lot of people know about J. Marion Sims. He's the father of gynecology. He invented a lot of gynecologic instruments and procedures, which we still use today. But these instruments were made, and these procedures perfected on Black slaves who didn't give consent and never received anesthesia. We all know about the Tuskegee study, and I put there the actual initial name of the Tuskegee study. And then we also probably know about Henrietta Lacks and the HeLa cells. If you don't know, I can explain once I'm done with the chat. But more recently, there's been a lot of data showing that if you're Black, and this was in patients presenting with chest pain or having some cardiac complaint, if you're Black, you're less likely to get life-saving intervention. So for providers and allies, when interacting with Black male patients, big thing is to understand that everyone is different, okay? And everyone's needs of care are different. There's actually, there was one study recently showed that Black men, especially elderly Black men, don't care about the credentials of the physician. They just care that the physician cares about their well-being. Also, understand that many of us, in a lot of these the studies that I just talked about, many of the physicians said that they had, I'm not racist, I treat everyone equally, but, when these studies were done, it showed that physicians have a lot of implicit bias. So understand that, there is implicit bias and you may have a bias. Understand cultural context, the historical treatment of Blacks, and that the decision to do certain medical procedures or interventions can be more complex and less straightforward than other demographics. And finally, if you ever have the chance, be a sponsor. I think one of the most touching things I've ever seen in medicine was when I was in training, one of my attendings who was on the sickle cell ward, she paid for an Uber for a patient who was being discharged, who would have to take the bus and hour and a half of transportation to get to her son's birthday. She got the patient an Uber. It was one of the most touching things I've ever seen. Okay, moving on to advice for navigating a cancer diagnosis. And I added this in because one of my good friends told me that I had to do this. So this is my advice if you're ever diagnosed with cancer or have a loved one with cancer, okay? One of the biggest things is to have support. So identify your support. For many people, it's a spouse, a partner, but it could even be your neighbor, okay? It's extremely important that you have support. And I see in a lot of Black patients lack of support. And sometimes it really makes me sad because you miss out on so much. It's also very important to record things. And if you have someone who's, driving you to your appointments and writing everything down, things go much more smoothly. You should also consider the financial implications. What I can say is that there are lots of resources out there for financial help for cancer patients. And most hospitals will have a team of people dedicated to financial issues. And then most hospitals will actually negotiate prices with you. When it comes to your oncologist or your surgeon, you should be comfortable with them. And even if you're comfortable with them, uh, you know, get a second opinion. It doesn't hurt to get a second opinion. Because again, Black folks have historically been very passive when it comes to their cancer care. So be, you know, more proactive and get, genomic profiling and enroll in a clinical trial. And speaking of clinical trials, we really need more Black folks, especially Black males, on clinical trials. So please, participate in the clinical trial or encourage your loved one to do so, because we can't have drugs approved for treatment of a tumor that you have when your demographic wasn't a part of the clinical trial that got the drug approved. And also, if you need help is always available. There's mental health specialists, supportive care, support groups, online resources. The last thing I will say is, if you know that your cancer is not curable, please consider an advance directive. It's a legal document that explains how you want medical decisions about you to be made if you cannot make these decisions. I can't tell how many times I've seen someone dying and they don't have an advance directive, and the family is fighting in between each other. They're fighting with the medical providers. It's just a mess. So I'm going to wrap up here. Hopefully, I've been able to shine some light on the alarming cancer disparities in Black males. Hopefully, we all now can list and understand some of the causes of the disparities, and that it's a very complex mixture of things that lead to this disparity, and that we now have ways of reducing these disparities, whether we be Black males, partners of Black males, families, providers, or allies. And I'd like to end by dedicating this lecture to my cousin Cassandra. She unfortunately passed away a month and a half ago from breast cancer. She was a lovely person, a beautiful soul. And working where I work, every day I see women on their 10th or 15th line of chemo. And she actually only lived a year from being diagnosed and only received one line of chemo. And the only difference between her and the population I see here is just the color of her skin and socioeconomic factors. So with that, I would like to thank the World organizers and Dr. Vicky Sapp and Dr. McBride. I'll take any questions if you have any.
Thank you so much. That was a fantastic presentation. And also thank you so much for sharing your loss. I think that is something that affects us also very deeply. We have about 10 minutes for questions, and I have a few questions in the slide in the chat box to start, if that's okay.
Yep.
This one is from Brian. He says, Brian Piper, given the high number of Black patients in the southern states, and many of those states have not expanded Medicaid, Texas is greater than 20% uninsured. Has the Medicaid expansion blunted some of these survival disparities?
So the literature I've read says no. The literature I've read says no. Yeah, because it's more than just, again, it's more than just having health coverage. It's, having, access to quality health coverage, and quality providers, having, transportation. Um, it's a little bit more complex than that. So, the ACA has, reduced some disparities, but it's still only part of the, very complex picture that leads to these disparities. Yeah, I mean, Texas, by the way, has has the largest Black population in the United States, which is sad.
This question comes from Shaylin Briggs. Do you feel that if Black men in this case, were given an opportunity or even access to resources to help with medical care, there would be more screening given?
Yes. So there's actually been studies and interventions where patients were given nurse navigators. Okay. And the rates of screening and also following up on the screening, because that's also a big issue with Black males is, if you get a positive result, what to do about it. And, if I have this cancerous polyp, where to go. With nurse navigators, there were higher rates of screening and following through. So, support is also important. And that's, I think that was illustrated in the clinical trial where the outcomes, because in clinical trial, there's a lot of support. There's there is, things are done very meticulously. So, with support, I think, we can really make a difference in these disparities.
I have another question from Shaylin Briggs. Why is the proximal colon the hardest to diagnose when it comes to cancer?
So it tends to not be as symptomatic as more distal cancers. Traditionally, rectal and, sigmoid cancers tend to bleed, lead to that bright red blood per rectum. The proximal colon cancers are less likely to do that. So, they're often diagnosed at a later stage. But apart from that, they seem to have a different genetic makeup that makes them more aggressive tumors, leading to poor prognosis.
Please stop sharing your screen, Dr. Wilkins.
Okay.
I think
Dr.
Townsend
Townsend has a question. You can go ahead, Dr. Townsend.
I do. Thank you so much, Dr. Wilkins. You can probably tell I'm one of the older members of this group, and I started my practice in New York and was there for 25 years in Harlem and the Bronx. I'm a family physician. And I wondered, your last comment was really relevant to what I was thinking about. I mean, even here at Geisinger, where the numbers of Black members of our community are relatively low percentage, and thus of our patients, we really should make an effort to understand what the rates of diagnosis, screening, health outcomes are. And this would be a great opportunity to be thinking about that. And I wondered if you could comment on other effective ways you've seen, say, primary care and specialty care, especially oncology and public health, work together to increase rates. Are there good models across the country that have happened? The nurse navigator example is a great example.
Yep. So there have been different things like screening through churches, screening and handing out information at barbershops. I also think read something about just making like a pamphlet about screening or educating about prostate cancer. If you make it or cater it towards black male or black female or whoever, they were more likely to read it. So simple things like that.
Good.
Right.
Thank you.
Awesome. Community engagement, I think, is huge when it comes to almost all disease processes, to be honest. Also, just to go back to that question about the proximal colon, just like Dr. Wilkins said, it's actually more difficult to get to as well. So the distal colon is the part that's closer to the rectum, the hole, so basically you have to have more skill to get all the way over to the proximal part. So if, someone who's African American is going to someone with less skill, the likelihood that they will successfully get all the way over to visualize that proximal aspect is much lower. So it's good to have a seasoned, good physician doing it, right? And in addition to that, you need to get good visualization, good colon prep, all of those things. And just like he said, it's less symptomatic, so it's harder to find. I have another question here, I believe. So why is 85 the age to stop for colon cancer screening? And this is from Zanette Davila.
So I'll be honest, Zanette, there's probably an answer to that. So all these recommendations come from lots of research. I am not completely sure, but because I don't do colon cancer anymore, but I think it just has to do with life expectancy and the fact that if if you're 85, you've already surpassed your life expectancy. And if you're diagnosed, the worst thing would be metastatic colorectal cancer, which people now are living up to 5 years with. So, I think that's the thing. But if you want to actually get the rationale, the U.S. Preventive Task Force, they have a very large document to answer that question for you. But I think it just has to do with the prognosis of the colon cancer and your likelihood of dying when you're 85.
We say the same thing about smoking. If you make it to 85 and you've been smoking 10 packs, I'm not gonna stop you now. Continue, everything in medicine is based off a risk-benefit ratio. And at that point, I think the risk of doing a procedure outweigh the benefits of preventing the disease when you hit that age. So they just say, continue and be free. Caw-caw to you. You've made it past the line already. I love it. So Dr. Wilkins, thank you so much. I actually have a question for you as well. So you named so many, wonderful ways of really attributing the difference between morbidity and mortality and risk when it comes to the African American population in lung cancer and colon cancer and in prostate cancer. What are some of the, you already named some of them, but what are some 3 things that you would do or you think need to be done to really change the scope of how things are going? Do you think that Black men need to be screened sooner? Do you think that we need to get more doctors of color out there? And do you think that we need to try to educate our community a little bit more regarding what those risks are and how we can avoid them in the future? And in addition to that, do you think that, access needs to be improved? What are some of the things the medical community can do to improve access to physician care and appropriate physician care in today's society?
So I probably discussed a little bit, for a lot of Black males, it's important to know that the provider has, identifies with them, has their best interest in mind. So I think one of the best things to do, and actually I didn't talk about how I work in disparities, but a lot of what I do is mentorship. So I'm also a instructor over at Weill Cornell. And I'm part of this thing called a mentoring cascade, where we basically have these groups comprised of, it's from first year medical students to, the chief of, the service. And we just meet and we discuss things. So, I think it's very important that we get more diversity in oncology, because it really, really helps. It's one of the, most important determinants. People, again, a lot of Black men, they don't care that you went to Harvard and you have, this and that. They just want to know that you care about them and you're going to do what's best for them.
I love that answer, to be honest.
Oh, you had a second question too, right?
Yeah. So I just wanted to know, what can outside of all of the sort of social determinants that we spoke to, what sort of things could the medical community itself do? You already sort of answered that, to be honest, because you said increased diversity, but and really be an advocate for your patient. So you sort of answered all of those questions in one, to be honest.
Yeah, but another big thing is implicit bias. Okay, understand. Again, those studies I would say, everyone is saying, no, I'm not racist, I don't have any biases, but we do, and understand that, and if you're one of those clinicians that are, saying, well, this person doesn't need this treatment, or it wouldn't make sense, or, kind of stop yourself and ask yourself, is this implicit bias? Is this, is this bias? Because, there's been a lot of research done showing that even the medical students, they have a lot of implicit bias. There's a lot of bias and prejudice in Black people. I think there was a study where medical students would kind of downgrade pain reports from Black patients rather than white patients, because apparently they think that there was some prevailing opinion that Black folks have thicker skin. So I think, understanding what implicit bias is and kind of checking yourself is also very important as a provider.
I really agree. You know, thank you so much for answering all of these questions. Thank you so much for your time. I'm actually going to let Priscilla take us out, if that's okay. Are you there, Priscilla?
Yes, I'm here.
So you want me to share the screen for you?
If you don't mind, if you have it ready, it'd be great. Yes, thank you, Dr. Wilkins. That was a great talk. It's such an important
My pleasure.
topic. And we're so happy that everyone was able to join us throughout this series. We've had some great talks and we appreciate everyone for coming. We still have our, if you can go to the next slide, please. Tonight we have two community talks still around the Amend documentary series. For tonight we have one. We're going over, I think, the 5th episode and then next week, we will go over the last and final episode. These community talks have been great thus far. We invite everyone to please join us, and we appreciate everyone's support throughout this month. This was our last event for a speech that we had, but again, we thank everyone for coming. Please don't forget to register for the mug. Daryl, I think you can advance the next slide, please. And again, thank you so much, everyone. And you guys all have a great day, and we hope to see you later.
I'll probably send you my slides tomorrow, Brian.
Thank you.
Do you, are you still there, Priscilla?
I'm still here, yeah. Can you hear me?
I can't hear you, Dr. Sapp, if you're talking.
Yes, we can hear you.
Okay.
Dr. Wilkins is still here. Does anyone have a
Do I need
question?
do I need to still be here? Or do
We were just wondering if people had questions. Just wanted to stay behind because they may have
Yeah,
had some
I'm here.
questions.
I'm here. I'm here. I've been reading through them. Thank you, everyone, for the condolence messages. Yeah, it's pretty. Yeah, it was a month and a half ago. She was so young, so it's
Yeah,
great.
very sorry for your loss.
Yeah.
You did a great job, Fran.
I think the last person that's here with us made a comment in the chat that she's interested in oncology. That's awesome.
Yeah. Okay. Oh, reach out to me, please.
Can you put your contact information in the chat box, please?
Okay. Yeah. Yeah. Definitely.
Yeah, that probably would be very helpful for her to grab it,
Yeah.
and she'll have it and she'll reach out to you. I love this when we make these connections with our students in the pipeline. Yes, please put that right in the chat. She will grab it and contact you and connect with you. You'll just make sure that you put that you're contacting from GCSOM, Geisinger Commonwealth School of Medicine, and he'll be able to connect that. And then you off to mentorship. This is wonderful. I love it. Thank you so much. I tell you, I put people to work, right, Dr. McBride and Priscilla?
Let me tell you, she definitely does that. I'm excited about tonight too. I'm gonna try to get out of here so that I can get home before we do the 5 o'clock thing for sure.
Yeah, that's a good plan.
And I'm actually going to be training the Detroit Department of Health.
Okay.
They're doing part 2 of my 3-part series, and that ends at 5. So I will be coming as soon as I'm done with them. We have like 10 minutes to close out, and then I'll be coming your way. I gave Priscilla the
Wow.
host controls.
Wow. Wow. Wow.
Thank you so much, Dr. Wilkins.
Yes, thank you. It was good.
Unfortunately, I'm going to get back to my very entitled patients right now.
Okay. Have a wonderful week. I have all of your
Yes.
paperwork, so you are all set. Have
Thank
a
you
wonderful
so
week.
much.
and thank
Thank you
Have
so
a good
much.
holiday. Thank you
Good
for.
job, Fran. Good job.
See you later.
Call me. Call me now.
Okay.
All right.
Bye-bye.
Bye.
All right, I have to go because I have to go to the school. So
Okay.
bye, guys. See you later.
Okay. See you tonight.
Oh,
Oh, are you gonna end it? Was it still recording? Yeah.
shoot. Yeah.